fifth episode of our Facebook Live session, Let's Talk Health. Today we have another renowned guest with us, Dr. Sirapani Gopalani. He is one of the best nephrologists in Hyderabad. As promised, we have come back with another exciting topic, kidney transplant. Let's discuss further with Dr. Sirapani. Welcome to this session, Dr. Sirapani.
Thank you.
Could you please tell us a bit about your experience and expertise and a bit about your background?
Okay, thank you for inviting me for this session. I have been a doctor for the last 20 odd years. I trained my MBBS, I did it from Visakhapatnam. After that, I went to UK, where I was there for a good 16 years. I got my specialty training from Oxford, following which I went into research field, and I got a PhD from University of Cambridge in autoimmune diseases. All through this, I have been closely linked and worked in very big transplant centers where we're doing close to 170, 180 transplants a year. So most of the expertise comes from having worked in big centers like Leeds, Oxford and Cambridge. Along with that, I also have keen interest in immunology, which formed part of my PhD thesis in dealing with autoimmune conditions. So that's my very brief background.
Thank you so much for sharing with us. Could you please tell our audience a bit about kidney transplant?
So kidney transplant is done in patients where the kidneys have stopped working. Primarily, kidney has a number of important functions that keep us healthy, like the toxin material accumulation. Every day we generate a lot of toxins within the body from the food that we eat, from the drinks and whatever that we do. So there is accumulation of toxins in the body. And kidneys help us to remove these toxins from the bloodstream. So that keeps us healthy. There is accumulation of these toxin materials, acids, salts, when the kidneys are not working. So in patients who have got kidney disease, they come to a stage where the kidneys can no longer keep them healthy. And in such situations, they would be needing either one of the two, either dialysis or a kidney transplantation to serve them with these functions of removing the toxins and keeping them healthy. So kidney transplant is primarily indicated in patients where the kidneys are no longer working. Thank you.
So what are the conditions indicated for a kidney transplant?
So a number of underlying conditions that affect the kidneys can lead to a stage of kidney failure. It's not like one particular condition. Like a lot of patients have diabetes, and diabetes, if not taken well care of right from the initial stages, can sometimes lead up to a stage of needing dialysis or kidney transplantation. So that's only one example. If you look at the data, about 25 to 30% of the patients on dialysis have kidney disease due to diabetes. So diabetic kidney disease is one of the major reasons why a patient may need a kidney transplant. Along with that, hypertension can lead to kidney failure and some of these rarer conditions that affect the kidneys primarily, like autoimmune conditions, for example, or some of these inflammatory conditions that affect the kidneys. All of these can lead to kidney failure. So it's not what is important is what type of kidney disease it is, but the kidney failure. So when the kidneys are not working, whatever be the cause of it, they may be eligible to have a kidney transplant.
So what are the benefits of kidney transplant as compared to dialysis?
So a kidney transplant does have a number of important benefits compared to dialysis. For example, if a patient is on hemodialysis, they will have to come 2 or 3 times a week, every week to the dialysis center. So their life actually revolves around going to the dialysis unit, going back, adjusting their work-life commitments. So it can sometimes get very tedious, and especially for young patients where they're still at the working age, then coming to dialysis 3 times a week can be quite labor-intense and tedious. So if you had a successful kidney transplant, then you have some better control on your life. So the quality of life is definitely much better when compared to hemodialysis. It's not only that, but also if you look at other parameters like the statistical parameters of how long a person lives after developing kidney failure. Patients that receive a kidney transplant, they tend to do significantly better compared to someone who of similar age group who is on dialysis. So not only the quality of life that is better, but also you are looking at benefit in terms of living longer when they had a kidney transplant. In addition to that, patients with kidney failure, they have significant amount of what we call as cardiovascular disease. So this is a state where the blood supply to the heart, blood supply to the brain is seriously affected. So this can lead to heart attacks and strokes. Patients with kidney failure, they're at much higher risk of developing this, and a kidney transplant can reduce such a risk. It's not saying that there are completely only positives with a kidney transplant, but compared to hemodialysis or peritoneal dialysis, these are the benefits I would think of when a patient had a kidney transplant.
So could you tell us the various types of kidney transplantation?
So, various types of kidney transplantation. I mean, primarily there are two that happen in India, but in total there are about 3 different types of transplantations. So the first one is what we call as live donor related or unrelated kidney transplantation. This is where your loved ones or people who want to make your life make the life of the patient better, they out of voluntary or willingness, they tend to donate an organ, like a wife donating to a husband or a mother donating to her son. So these are the situations where we call it as a live donor kidney transplantation. So the other kidney transplantation that we have is called cadaveric kidney transplantation. Here there are 2 types of different methods. So one is called, also called as deceased donor kidney donation. Either we can harvest an organ from a situation called brain death. So where the patient's organs are still working, but technically the brain is considered to be not anymore salvageable. In such situations, we can harvest the organs before they remove the supports to the patient, like the ventilator and other things. Even though the patient is technically considered not alive, we can harvest the organs in a much healthier situation. Another type of deceased donor kidney transplantation is called after cardiac death. These are the situation. I mean, these transplants are not so commonly done in India, but definitely done across the world. The outcomes of these can be slightly less compared to a brain dead patient, but that is also another type of transplantation that can be done. Thank you.
So is there a difference between a live and a deceased donor transplantation?
You mean in terms of the survival of the kidney? Yeah. So with the improved outcomes that we're seeing with the latest immunosuppressive medications and the care pathways that we have at this point, I could only say a marginal difference between these 2 types of organ transplantation in terms of the survival. So historically, from around the world, the experience suggests if someone has a deceased donor kidney, the median life, which means about 50% of the transplanted kidneys will survive for 11 years, and the other 50 may be lost due to various reasons within this 11 years. When we compare this to the live donor kidney transplantation, the average or the median survival of a kidney transplant is about 15 to 16 years. So definitely live donors, they tend to do better as opposed to deceased donors. So there are many reasons for this behind this. One is if it's a live donor, it's in a much more controlled fashion where you pre-assess the donor, we pre-assess the recipient, we take all the necessary precautions, get them ready for the surgery. As opposed to a deceased donor, this becomes more of an emergency operation because you can never predict, as the deceased donor organs become available, it could be either in the middle of the night or it could be any time. So it becomes more of an emergency procedure. And not only that, you don't have much control over assessing their immunological risks. Deceased donors tend to be doing slightly less better. It doesn't mean it's a huge or a gross difference, but these are the considerations we have to take into account.
So Dr. Sirapani, could you please share the end-to-end process of kidney transplantation?
The end-to-end process of kidney transplantation, it can be quite simple, at the same time quite complex. Okay. It all starts by assessing the suitability of the recipient first. Okay, we would not recommend a kidney transplant to someone who is frail or whose life expectancy is expected to be quite short, because the risks associated with the kidney transplantation or in the process that they have to go through can be quite taxing at times. So choosing the right patient is the most important first step. So all the patients with kidney disease, as I have previously mentioned, they have a high risk of cardiovascular morbidity, whereby they could have some issues with their heart. So the first assessment that we always start with is understanding the risks that we're going to put the patient through by assessing their cardiac status. So the cardiologists have to thoroughly assess these patients and give us a first clearance to say, yes, it is in the best interest of the patient. Even putting them through this process, they are able to withstand it, and not in the process we're going to cause them any harm. Okay, that is the first thing that we always do. Along with cardiology, we also need clearances or approvals from multiple different specialties, including gastroenterology. For example, some of the dialysis patients may have some of these viral illnesses like hepatitis B, hepatitis C. So we have to thoroughly assess them on those fronts to understand that they are risk-free from those. Not only that, getting an opinion from the pulmonologist, making sure that their lungs can support them. Another important sort of factor in assessing these patients is the psychiatric clearance. So mental health is very common in these patients, because even despite our best efforts to give them a good transplant, if they're mentally, they are not capable of taking the medicines, or there is any issues in terms of non-adherence, then all the efforts are wasted. So we also assess these patients for psychiatric conditions, and we need an approval from the psychiatrist to say, yes, this patient can take the medicines. There is no mental health illness that we are worried about. And then we obviously need the review from the urologist or the transplant surgeons who does this transplant surgeries, anesthetists. They have to assess their anesthetist risks and confirm that the risks are lower compared to the benefits we may get out of this. This is a process which takes over a period of a week to 10 days, where we get them to see different specialists. We get different blood investigations. We also understand the nature or the current status of the blood vessels, because most dialysis patients they can have thickened arteries. So a process, a series of tests are done to establish this surgery is in the best interest of the patient, and the patient is going to benefit from this surgery. If at any point we find problems with any of these tests, we may have to say, yes, this is not a surgery right for you, because we may put you at more harm than any benefit. So choosing the right recipient is the first step. Okay. Along with that, we also need to have a donor. Okay. Either if it is cadaveric donor, then we register these patients under a government scheme called Jeevan Dan, whereby each patient is given a different scoring based on the number of years they've been on dialysis, the availability of dialysis access. The different parameters are taken into account, and depending on that, each patient is given a scoring, and they go into a wait list. So once the organ is available, they are called in, and then the transplant surgery happens. So that is for the cadaveric donation. But in the live donor, there can be two different options. One is live related, and other one is live unrelated. For example, if a spouse, like wife or a husband, wants to donate it to their spouse, then it becomes live unrelated kidney donation, because they're not genetically related. But if a mother or a father or brothers give it to their relative, or a son or a brother, then that becomes a live related kidney donation. So what is very important in these situations is having the right donor. So the donor, if they are closely and genetically related, they tend to do better compared to unrelated, but this difference is marginal. Okay. So having the right donor. So once you have identified the donor, there are two things that we have to do. One is understand their blood group compatibility. So not every person can donate to every patient. So they need to be blood group compatible. For example, a O positive donor can give the organ to any of the blood groups, as opposed to a O positive recipient can only get the kidney from an O positive donor. Okay. So these things we have to take into account. Once we found a suitable donor, and we know they are blood group compatible or incompatible, then we start the subsequent process. the most important thing here is the safety of the donor, because the donor literally is not a patient. They're having a surgery for not their own benefit, for the recipient's benefit. So we give utmost priority to ensure that we are choosing the right donor, and we mitigate or reduce the risks associated with such a surgery, and we thoroughly assess them to reduce this risk. So they also go through the similar process of getting approvals from different specialists, including the cardiologists, urologists, gastroenterologists, psychiatrists. And so they go through the process. At the end of it, we want to make sure that the donor is healthy. There are no complications that we are likely to encounter as a result of this surgery. So once that assessment is done, then what we subsequently do is assess the immunological risk. Okay, this is essentially, until now we have done the donor and recipient workup generally to understand the risks of going through the surgery. The most important thing that comes at the end is immunological risk, because the human body is designed to reject anything that is not their own. Okay, for example, the most of the times we see bacteria, viruses, fungus, these things the body is always trying to reject or destroy them. So the human body is designed in such a way. When we are implanting or transplanting an organ from a completely foreign person, the body's natural tendency is to go attack, kill it. Okay, this is what we call as rejection. So we do a series of tests to understand these risks. Okay, is the patient, is the recipient ready to receive an organ with less immunological risks? Only then we proceed. So there are a series of tests that we do. We do tests called HLA typing to understand the disparity between the donor and the recipient. We also do certain tests called cross-matching to see if the donor has already got preformed proteins that are going to go and attack the kidney and kill it straight away. So we do this test to understand this risk. Once we know for certain that there is no risk of this acute rejection, then we proceed with the kidney transplantation. The surgery itself is done by the urologist or by the transplant surgeons, and there is a thorough assessment by the anesthetist before they take them to theatre. And within the theatre, the first thing that happens is what we call as donor nephrectomy, which is the process where we remove the kidney from the donor for transplantation into the recipient. This is generally done by two different methods, and the easiest is called what we call laparoscopic nephrectomy, which where the donor is the nephrectomy is done within short span of time with limited complications, and the recovery is also much quicker. And once the kidney is harvested from the donor, then the recipient is also prepared for implantation of the organ. And this whole process takes about, for the nephrectomy, about 1.5 to 2 hours. And for the recipient, the surgery lasts for about 3 to 3.5 hours. Once the surgery is done, they're taken back to ICU for 24 hours. Initial periods are associated with significantly high volumes of urine, so we have to carefully monitor them, make sure that they're not getting dehydrated, because the kidney, it takes a little bit of time for it to get adjusted, and initial phases they pass a lot of urine. So once this acute phase is finished, then we transfer them to the ward, and they're kept in the ward for about 5 to 6 days. There are lots of different tubes that are initially placed, and at the time of discharge these are removed, and then the patient is discharged. There is always a stent that is placed for the first 3 weeks, and this is removed at 3 to 4 weeks, depending on how the patient is doing. So the most important aspects here are what we call as immunosuppressors. Because the body is always trying to reject the organ, we suppress the immune system to keep it from rejecting the organ. And these medications are very powerful medications which are going to affect or alter your immune system. So close monitoring is extremely important. One, to understand the medicines are working and doing their job in preventing the kidney transplant from getting rejected. Two is that we are not overdoing, because it's a very fine balance. It's almost, I compare this to doing a tightrope walk on a very high altitude. Okay, so you got to balance your act. Not give too much of immunosuppression, not too less. Okay, if you give too much immunosuppression, there is a high risk of infections. If you give too less, there is a high risk of rejection. So it's a fine balance that we have to do. And in this process, what helps us is frequent monitoring in the form of blood tests and assessing the patient clinically. Based on that, we will have to keep adjusting the medicines for the first 3 to 6 months. And once we achieve a period of stability, the visits tend to become less. Okay. So the overall, if you look at the renal survival, the graft survival, which is like at 1 year, about 98% of the kidney transplants do work. The 2% of the kidney transplants can be lost due to a number of different reasons, be it surgical, be it immunological, be it rejection episodes, or be it infections related to immunosuppression. We may lose 2 kidney transplants. So this is generally from start of pre-assessment to surgery to post-transplant. This is what is generally expected.
Thank you so much for sharing. What to expect after a transplant?
Well, the expectation is, as I said, the first few months will be quite intense in terms of monitoring, but patients can more or less get back to their normal life. They can go back to work, they can exercise, they can drive a car, they can go on holidays. So, but we got to be mindful of the risk of infections. So we would generally avoid them not to go into heavy crowds. Use universal hygienic measures like hand washing and hand rubs. These are important. Try and avoid people who are unwell with the flus and viruses. Keep away from them. But more importantly, not to miss the appointments, not to miss the blood tests. And these tests are not to diagnose a condition. These tests are all in a proactive fashion, okay? So that we identify a problem before it becomes too big. So that we take the necessary steps to reduce or mitigate the risk of it getting bigger.
So what are those risks of applications?
So, I think it's an important question because, as I said, we are modulating the immune system. The main risk that we are all worried about is infection risk. And especially in Indian subcontinent, where sometimes either it could be overcrowding or general risk of infectious diseases which are much higher. It tends to be we have to be very careful with this. So the risk of infection is what we are mainly worried about. So we take some necessary precautions to reduce this risk. So for the first few months, we put them on various medications to reduce this risk, such as Septran to reduce the bacterial infection. We put some medications to reduce the viral infection risk. We put them on some medications to reduce the fungal infections. So the first, because the immunosuppression is the highest, is just highest intensity in the first few months. So during such period, we advise ensuring that we protect the patient and give them all these medications to reduce this risk. And this risk, as we go down the months, is reduced because we also reduce the immunosuppression as we go along. So infections are one major risk. The second risk that we need to briefly talk about is side effects of the medications. Because these medications, as I said, are very potent and powerful. They can have an effect sometimes on the liver. They can have an effect on the bone marrow. They can have an effect on the kidney itself. So we have to keep monitoring and tailoring the medications to each patient. It's not the same for every patient. Each patient is different. So this is where the tailoring happens. The other risks in the immediate post-transplant period, the risks of related to surgery, complications like infections at the site of the surgery. Or some complication in relation to this joining of this organ to the human body. These are quite rare, but expected risks that we know can happen. The other risks I'm talking about in the long term are risks of slightly increased risk of cancers. Okay. This is so small, I don't think it's worth discussing too much about it, but like with any medication that you're taking, these risks exist. Other than that, I think is generally monitoring is what will help us to get out of these complications before it happens.
So how much time does it take to recover after a period?
So if it's a completely smooth transplant where there are no major hiccups, a patient is out of the hospital on day 6. Okay. 6 days, yeah. Occasionally, depending on various parameters, either minor reactions to the medicines we give, or they have too much of urine output that becomes a little longer, takes a little longer to settle. It may be 10 days at the most. But most patients are out of the hospital by day 6.
Can the disease reoccur after the transplantation?
So yeah, disease reoccurrence is a well-recognized phenomenon. Um, so there are certain conditions where the disease can reoccur. So we have to we usually counsel the patients before they are transplanted, discussing the possibilities of reoccurrence. It's not that it happens in all the patients, but some patients it does. Conditions such as FSGS, IgA nephropathy, hemolytic uremic syndrome. These are the situations where the disease can reoccur, and we try and counsel the patients adequately before we do take them up. There are certain absolute contraindications where you may not want to do the kidney transplantation. I mean, I cannot say absolute. They used to be absolute in the past. For example, hemolytic uremic syndrome. Now, with the availability of certain medications, transplantation is still possible in these patients. The reoccurrence is not uniform. Not every patient with FSGS or IgA will have a reoccurrence of the disease. And even if it reoccurs, it does not mean that the kidney is going to stop working immediately. Because, for example, IgA nephropathy, the patients typically can take up to 10, 12 years for them to develop renal failure. Similarly, in the transplanted kidney, the disease may take another 10 to 12 years, which usually is the average lifespan of the kidney anyways. So that should not make a huge difference.
What kind of lifestyle changes would you recommend for after transplantation?
Yeah, I think it's a very important question because a lot depends on how a patient looks after themselves after the transplant surgery to one, keep themselves healthy and maintain the health of the kidney. Some of the medication that we use for rejection, like the tacrolimus or cyclosporine, they can lead to certain conditions like diabetes. It's well recognized that these medications and the steroids that we use can cause diabetes. So they have to take sort of adequate active lifestyle measures to reduce this risk. So that involves watching their diet, reducing the carbohydrate intake, reducing the salt intake, exercising on a regular basis. This will help to keep them away from developing these diseases. And sometimes, despite all the precautions we take, they may still develop diabetes because that's the nature of the drugs. And in such cases, in order to reduce the intensity of the disease, like the diabetes, these measures still help them. So these are universal precautions they should be taking all the time. Steroids have a number of side effects that include thinning of the bones to developing diabetes to putting on weight, obesity. So again, the active lifestyles like regular exercise, drinking plenty of water, avoiding and reducing the salt intake will take them a long way.
Thank you so much for sharing your valuable insights with us. Would you like to share a final comment with us?
Yeah, thank you. I think kidney transplantation can revolutionize the life of a patient. There are a number of important things that, as I discussed, we have to take into account. Choosing your right patient, having the right donor. The utmost important thing is not to cause any harm to the donor, and assessing their immunological risk thoroughly. Then you'll have a successful transplant. And for all of this, you need the expert physicians who can help you, guide you through the process. Thank you.
Thank you for joining us today.
Thank you.
Thank you for tuning in to our today's Facebook Live session, Let's Talk Health with Dr. Sirapani. Don't forget to mark your calendar for next Friday at 4 p.m. when we will be coming with another exciting topic. Till then, stay healthy and stay informed. If you have any comments, leave them below.